Hello, everyone, and welcome to the first NDARC webinar of 2025. It is my absolute pleasure to be hosting today's webinar. My name is Kriana Barat. I am a research fellow at the National Drug and Alcohol Research Centre and co-chair of this webinar series, where we aim to highlight national and international work from experts from the field of alcohol and other drugs. I'd like to begin by acknowledging the Whadjuk Noongar people, who are the traditional custodians of the lands from which I work upon. It is a privilege to be tuning in from Whadjuk country, and I'd like to extend my acknowledgement to the traditional owners of the lands that you all may be gathering on today. Now, it is my pleasure to introduce today's speaker. Dr. Emmert Roberts is a consultant addiction psychiatrist and senior clinical lecturer in addiction psychiatry at the National Addiction Centre, King's College London. He is a senior Harkness fellow and currently holds a 5-year National Institute of Health and Care Research Advanced Fellowship to work within the UK Government's Department of Health and Social Care. His fellowship project aims to use linked data to derive and validate clinical prognostic risk scores for mortality and recurrent hospitalisation among people with substance use disorders. And in today's webinar, Emmert's presentation will provide an overview of the development of one of these models, predicting individualised 6-month mortality risk in people with opioid use disorder from data from the UK. I am pleased that during the Q&A session, we will have the opportunity to have our own Professor Michael Farrell, Director of NDARC, join us. Both Emmert and Michael will take questions from the audience after the presentation. Please use the Q&A function within Zoom to log your questions, not the chat function. And I will try to relay as many of those as I can at the end of the presentation. Without any further ado, Emmert, I'll hand over to you.
Thank you so much, Kriana, and thank you to NDARC for asking me to talk today to you all. So yes, I'm Emmert, I'm from the United Kingdom. I normally work in King's College London, but I've had the great opportunity to come to NDARC for the next 3 months and learn about all things Australian. Fear not, Australian colleagues on the call. I am stocked up on sun cream and have brought a large brimmed hat with me. But enough of that. So today, I'm going to talk to you a little bit about some work that we've been doing in the United Kingdom around trying to individualize addiction treatment a little bit more than it is currently. And part of that is trying to develop a prediction model to estimate individualized 6-month mortality risk in opioid use disorder. So just a little bit of background first around England. So last year, England reported its highest number of drug-related deaths on record. And I think it's really important. It's often the first part of a background slide whenever I give talks like this, that sort of states a really stark, horrible statistic around drug-related deaths. Obviously, this is happening all over the world, but each one of these deaths is preventable. Each one of these deaths is a person. And I think it's really important that we acknowledge the huge amount of morbidity and mortality that's caused by these substances. But just to give you, like I say, a little bit more background on the United Kingdom, opioids were implicated in about half of those drug-related deaths, of which there were about 5,500 in England last year. And opioid use disorder itself was an issue for about half of people presenting to our community addiction services. So opioids are by far the largest drug group of people that we treat when we see people in addiction services. And thanks a lot to a lot of Australian work that's actually been conducted within NDARC, we know due to the evidence that on average, people with opioid use disorder have about 10 times higher standardised mortality rates than compared to the general population. But it's really difficult when you're in clinic and you're sat in front of a person to try and perhaps convey that information of that elevated risk. It's also really difficult for addiction services because different people are going to have differential risks of death within the next X amount of time. And so sometimes we can think that everyone who presents to our services is risky, but there are obviously grades of risk, and some people being higher risk of mortality than others. And that presents challenges, because it presents challenges in terms of conveying those risks to the person in front of you, but also in terms of risk stratification. So are there interventions that we should be delivering faster and more promptly to people who are more risky, or are there people who, if they drop out of treatment, we should really be trying to get hold of them due to their elevated risks? And this isn't true in a lot of other areas of healthcare. So expansion in what we call clinical informatics and sort of precision or personalised medicine has really revolutionised many other areas of healthcare. You might have heard of models called some things like the Q risk, which estimates 10-year cardiovascular risk and ascertains whether or not people should be given statin or cholesterol lowering drugs. There's also scores like CURB 65, so assessing through whether or not you need antibiotics or your risk of death in pneumonia. But development and validation of sort of prognostic tools and prognostic scores within addiction has been much more limited. And there's a couple of reasons for this. It's often very difficult to get large-scale data sets together, and particularly data sets that link up treatment service data with administrative death records. So for those reasons, over the last sort of year or so, we've been working with clinicians and with people with lived and living experience of opioid use disorder. And what we wanted to do was take information that was collected at a routine baseline assessment. So when a person walks through the door of an addiction service in England, using that information to try and develop a prognostic score. So to be able to give someone an estimated risk of two things. So the first, their risk of death within the next 6 months due to any cause or all-cause mortality, and their risk of death in the next 6 months due to specifically a drug-related cause. So that's what we set out to do. So the way this study is reported is in conjunction with international guidelines, which have been recently published in the British Medical Journal, called the Transparent Reporting of Multivariable Predictor Models for Individual Prognosis or Diagnosis that Use Regression or Machine Learning. Bit of a mouthful, and so they shortened that to what they call the tripod plus AI statement. So what I'm about to present is reported in accordance with those guidelines. As I said, the study benefited hugely throughout, from sort of study inception right up until interpretation, and what I'm going to share with you today, both from my fellow clinicians in drug and alcohol services in the UK, but also from the Service User and Carer Advisory Group, which includes experts with lived and living experience of opioid use disorder. So what data did we have? So we had data on a 10-year window from April 2013 to April 2022 to any adult who attended community addiction services in England and who received a diagnosis of opioid use disorder. And we linked 3 national data sources. So we linked people's community addiction treatment records, so that contains information on things like the kind of drugs they were using, what kind of treatment they received, and that's collated in a large-scale database called the National Drug Treatment Monitoring System, or NDTMS. We had information on their inpatient hospital records from a system called Hospital Episode Statistics. And finally, people who died, we had their death records from our Office of National Statistics. And through a process of data linkage, we were able to put all those 3 things together to try and develop these models. So we wanted to try and understand what kind of things that we collect routinely at baseline assessment in addiction services could predict risk of death in the next 6 months. And we identified these, like I say, from a large majority of global systematic reviews, most of which were conducted out here in Australia. And we discussed those risk factors with our clinicians and patients to come up with a short list. And what the clinicians and patients told us, and I think people working in services will know this, addiction services are often fast-paced, they're often time-pressured. There's often a different kind of skill mix of people who are doing the assessments and initial triage work. And so any model that we came up with, any questions that we had to ask, had to be easily incorporated into routine clinical care. And the feedback that we received initially was that there should really be no more than 10 predictors or 10 questions in the final models. That was deemed a reasonable amount of things for people to input to try and calculate someone's risk. So we agreed from the outset, based on the systematic reviews, based on our discussions, an agreed set of 13 potential candidate predictors that we extracted from our linked data set that were taken It's a baseline assessment in community addiction services. And here are our list of 13. I'm sure most of them will be familiar to people who work with people who experience problems with opioids. So how old someone is, their sex, their accommodation status, had that person previously been in addiction treatment, had that person previously been admitted to an acute hospital, had they previously been detained under the Mental Health Act in a mental health hospital, have they had a recent history of incarceration in prison, what's their current injecting status, do they have any other substance use disorder diagnoses other than opioid use disorder, what's their HIV status, what's their hepatitis C status, and do they have any current problematic use of alcohol or benzodiazepines. Like I say, the outcome that we were looking for was so death within the next 6 months due to either any cause or the subset of that due to a drug-related cause. And for drug-related causes, our government has a specific set of diagnostic codes within the International Classification of Diseases, or the ICD-10, that it counts as a drug-related death. And yet those deaths, like I say, had to be within 6 months of attending the community addiction service. There was obviously some missing data within some of those, and we addressed that using a technique which I always find quite sweet, called MICE, or multiple imputation by chained equations. And we developed the risk model that I'm going to talk about using multivariable Cox regression. So it's a regression statistical model to try and estimate risk. And just as a little aside here, we can talk a little bit more about it towards the end, but we chose very specifically not to use machine learning. And that might be a surprise to some people. There's been a huge interest and outpouring of use of AI techniques and machine learning techniques to estimate or predict risks in a whole variety of healthcare conditions. But the feedback that we got from our patients and clinicians was that it would be like running before we were walking in addiction services. People were very distrustful of machine learning models. People didn't know what was under the hood, how they would be interpreted by patients and indeed by professionals who would be delivering the information around risk. So we were clearly steered towards use regression. Professionals felt much more comfortable with that because it's models that or other models that exist like it in other areas of healthcare they were comfortable with, and it was felt that this would be a good first step to estimate rather than trying to use more sophisticated machine learning mechanisms. And then there are two ways that you assess how good your model is once you've built it. The first is discrimination. So what discrimination tests is how good the model is at telling two people who are very close together apart. So for people's risk, did they die or didn't they, if they have very similar risk factors. So you can use some statistics called Harrell C and D statistics. For those of you familiar with Cox models, they're very similar to a statistic called the receiver operating curve, the ROC curve, but they account for the sensitive nature of the data. So you're looking for good results in these statistics, and I'll talk a little bit more about them afterwards. And the second thing that we do, so how good is discrimination, but also how good is calibration. And what calibration assesses is how accurate your model is in terms of predicting what you actually observe. So if you observe 20 deaths, does your model predict 20 deaths? And how close is it to that? So finally, some results. Sorry for the very long preamble. So we had data available for just over 236,000 people over the 10-year period who were diagnosed with opioid use disorder. We think this is the largest linked data set globally out there in terms of mortality at the moment, in terms of individual numbers. And to give you an idea of the number of deaths, so there were just over 2,400 deaths due to any cause, and about half of those were due to drug-related causes within 6 months of the presentation to community addiction services. And just to give you a little idea of the baseline characteristics of this group of people, so their mean age was about 43, about 73% were male, 65% reported no housing issues, relatively typical for people with opioid use disorder in the UK. 42% had never injected, 14% had current problematic alcohol use, 7% had current problematic benzodiazepine use. 65% had a previous history of addiction treatment, so the majority had been in treatment before, which is similar to what we'd expect in international samples. About 2/3 of them had previous admission to an acute hospital, and less than 1% of them had a formal detention in a mental health hospital. But about 15% had recently been incarcerated in prison. around a 1% prevalence of HIV positivity, and about 4% were currently hepatitis C positive. And that's either, that's both, they have hepatitis C RNA positivity, so they have not cleared the virus if they've become infected or they've never been infected previously. So, thinking first about all-cause mortality. So when we ran all of our 13 predictors that we discussed with our patients and clinicians and amalgamated from previous systematic reviews, all the predictors that all those 13 predictors were predictive of all-cause mortality apart from 2. So HIV positivity and the number of substance misuse diagnoses were not predictive, and so they were excluded and not put in the final model. If we look at those 2 statistics that I was talking about how good the model is, so first looking at discrimination, the D statistic, you want a statistic that's over 1, so that's successful. And for a Harrell C, you're looking for anything that has sort of what's classified as good discrimination is above 0.7. So we're at 0.73, we tick both of those boxes for this model. And if we look at calibration, so how accurate, how is it predicting what we observe, you want scores that are around 1. So you're looking for a ratio. And again, we have a pretty good calibration of 1.01. Apologies for this table, it's a little bit busy, but let me talk you through it. This is the results of the model. So along the, say the left-hand column as I'm looking at it down here, you see all of our variables, our candidate predictors. These are the different reference points within the candidate predictors. And then in the final column is the hazard ratio. So this tells you how much more risky it is being in one category than compared to the other. So if we take, for example, accommodation need, you'll see that if you had a housing problem at baseline assessment compared to no housing problem, you have a hazard ratio of 1.13, which basically means an increased risk of about 13% in your time to dying within the next 6 months. So any hazard ratios above 1 are going to increase your risk of the event. So that's the lowest risk of all of the candidate predictors. And if we look at the highest one, so we can see that if you're a person who's been previously previously detained in a mental health inpatient hospital compared to never having been previously detained in a mental health inpatient hospital, your risk of dying within the next 6 months goes up by about 123%, so 2.23 as a hazard ratio. So these 11 predictors all predict all-cause mortality, and the hazard ratio gives you an idea about by how much. If we look at drug-related mortality now, it's a very similar story, but all the predictors were kept in the final model, except HIV positivity, the number of substance use diagnoses, but also age. Age wasn't predictive of drug-related mortality, interestingly. Discrimination, we see very similar results. We get a good D statistic above 1, we get a good Harrell C statistic above 0.7, and we get a calibration curve slope that is very close to 1. So again, we're quite happy with how accurate these models are. If we look at our drug-related death hazard ratio, we can see that the lowest statistically significant increase in risk is if someone had been previously admitted to an acute inpatient hospital compared to never having been admitted to an acute inpatient hospital before, an increased risk of about 13%. And reassuringly, in terms of model development, we can see that one of the biggest risk factor for drug-related mortality is currently injecting. So for people who are currently injecting, compared to never having injected, your risk is increased by about 187% to drug-related death within 6 months. So what does this all mean? So it's all, it's all well and good me sort of telling you lots of numbers about increased risk and, the percentage of higher risk of this and this. And as I said at the beginning, that doesn't necessarily help the person sat in front of you. So what we can do with all this information is put it into an application that tells us people's risk within the next 6 months. And I'll just give you a few little examples of this. So this is patient number 1. If they're a made-up person, I've just I've put in a few variables to see what kind of risk that they would come up with. So person comes into you in front of you, diagnosed with opioid use disorder in your addiction service. They're an 18-year-old female who's never injected. They're negative for hepatitis C. They don't have any problematic alcohol use. They don't have any problematic benzo use. They've got no housing problems. And as you can see, everything else is negative. So their baseline risk of all-cause mortality at the bottom of this table is about 0.8%, 0.86%, or their drug-related mortality risk is about 0.42%. So if there were 100 people coming into your clinic with similar risk factor profile as this lady, less than 1 in 100 of them would die within the next 6 months, or 0.86% of them would die within the next 6 months. If we change up those risk factors a little bit, so now we have a 52-year-old man who has previously injected, but he's negative for hepatitis C. He's using alcohol problematically, but everything else is pretty stable or not increasing his risk. But he does have a previous history of addiction treatment. His risk jumps to about 10.32% all-cause mortality. So again, if there were 100 people sat in front of you with his risk factors, 10 of them would die would be predicted to die within the next 6 months. A 66-year-old male who's currently injecting. He's negative for hepatitis C, but he is problematically using alcohol. He does have a housing problem. He's previously been admitted to an acute inpatient hospital, and he's got a previous history of addiction treatment. His risk goes up to 1 in 4. And finally, a person who's experiencing a significant number of risk factors. So a 53-year-old male who's currently injecting, has problematic use of alcohol and benzodiazepines, has a housing problem, was previously admitted to an inpatient hospital acutely, a mental health inpatient hospital, and has a previous history of addiction treatment, has a risk of about 38%. So roughly just over 1 in 3 people who sat in front of you with these risk factors would be dying due to in the next 6 months. And so what we've done as part of this is create a web application that would be available for people, for professionals and patients, to the person who sat down in front of them when they come in for their addiction treatment. The QR code is at the bottom of all of these slides if you want to have a little look at the website, or I'm going to try through the magic of technology to show you now. So if I stop sharing my screen and then try again. Can people see that? Some form of... Okay, I think people can see that. The joys of being on Zoom. So you can see this is just, it's a web calculator, so it's available to anyone. And you can just fill in, as you would, the demographics of the person in front of you. So they're a man, they have an urgent housing problem, they currently are positive for hepatitis C, and they're currently problematically using benzos, and it will give you at the bottom here a risk score for their predicted all-cause mortality in the next 6 months and drug-related mortality in the next 6 months. It also contains a link to our protocol, which has been published. The final model of this, just to say, is currently under review in a journal, hopefully to be published ASAP. So that's the web app. Let me go back to... and hopefully you can see that. So, thinking, those are the results of our model. So a little bit of thinking about what this means, what this could mean for clinical practice, what this could mean in terms of risk prediction. So what we did was we developed and validated 2 models to estimate 6-month all-cause and 6-month drug-related mortality risk for people with opioid use disorder who presented for baseline assessment at community addiction services. And as I've said before, there's a balance for this need between how accurate and how good the performance of this model is, and the parsimony, so how few variables it has, and the usability and the ease of usability within it. Obviously, what we could do is have a score that had 30, 40 risk factors in it that increased the accuracy of the score, but that would be trading off against the usability of it. So I don't want my recovery workers there spending 40 in my service that I work at South London, spending 30 minutes trying to painstakingly go through 40 different questions that might have quite complicated answers and might be misinterpreted in order to just gain a very small amount in terms of accuracy. So it is a trade-off between, like I say, model performance or model accuracy and the amount of information that you can put in, particularly given that this score or the web app might be used by people with a very different kind of skill mix within addiction treatment services. The majority of our workforce Our addiction workforce in the UK are non-clinically trained. They're recovery workers, either with people of personal experience of substance use or professional experience. So the likelihood is that this would not be used by clinicians, which is one of the reasons that it's that you need to think about these kind of trade-offs throughout the model development process. And both models are intended to calculate risk at baseline assessment. So all of these risks conveyed to the individual are done at a time of baseline triage assessment within addiction services. So this is a time period where people are not on treatment or not in receipt of any treatment for any kind of addiction disorder. So they're not on OST, they're not receiving any psychosocial input. This is their baseline risk because they're sat in front of you at a triage assessment. One of the post hoc, or one of the things that we did after we developed the model, is to see whether or not putting into the model whether or not people remained in treatment at 6 months, if that was protective. And it was significantly protective. So it reduces people's risk, not quite down to their baseline risk, but it does reduce their risk. It does reduce their risk down significantly. And that correlates to what we know about OST in terms of reduction of risk compared to being off OST by about 3.5 times. So providing individualized risk to people at this clinically important time when they first present to addiction services might have the potential to do a couple of things. So it might result in internally generated behavior change within that individual to address those modifiable risk factors within the variables that we've used in our model. And also to say, look, if you remain in treatment, these risks, these risks are almost certainly ameliorated within the next 6 months. So it's a carrot to try and both address certain risk factors, but also to remain engaged in protective treatment that we know reduces the risk of death. And secondly, as I mentioned at the beginning, it can help assist professionals in the prioritization of finite resources. Certainly within the UK, we have a huge workforce crisis, and we have a depleted number of prescribers who are available on that day to prescribe at OST. And if if you have someone who came in who is incredibly high risk objectively, from this risk score, you might be able to prioritize getting them in front of a prescriber ASAP, or you might be able to do something that if they drop out of treatment, there are some people who could be prioritized very specifically for assertive outreach, or we know we definitely need to get those people back in because they're very likely to die within the next 6 months. At the moment, we sort of thumb our finger in the air and say everyone's high risk and it's all based on clinical judgment. No, they're an injector, but also they're experiencing homelessness, and it's less objective, and it can create a little bit of chaos sometimes, I find, in my services in particular. So if we had an objective score, that might be able to help us prioritize or target more effectively than we do currently. So just a few strengths and limitations of what I've presented. So it's a very large, comprehensive, non-selective and national data set. So hopefully it captures everyone who's coming into addiction treatment. Just to say, we don't have a large private, we can have, well, almost have zero private community addiction services within the UK. So the majority of people with opioid use disorder, if they were presenting to services, would be able to do so free of charge within community addiction services. There's very little OST that's provided privately. There is some private detox and some private residential rehabilitation, but the nature of these kind of people are that they're incredibly likely to come to statutory services. We involved patients and clinicians from the outset who provided invaluable advice throughout the entire process. But as I've mentioned, particularly in terms of the outcome predictor selections, they were the ones who advised that 6 months was a reasonable time point to think about studying. A year can seem very far away, a little bit closer could seem a bit pressuring, and 6 months was sort of settled on. They were the ones who gave us quite strong, clear indications as to which predictors they felt would be able to be used by staff and understood by patients. And like I said, they steered us in a very clear direction with regard to machine learning approaches. Just to say, all of these predictors are collected retrospectively from what is an ostensibly administrative data set. It's not a clinical data set. And there's obviously potential for information bias within that, and a risk of lack of availability of some questions being answered or knowledge happening. That being said, that is the reality in clinical practice, that we don't always have access to all of the information at that time, and it reflects the nature of clinical work, that there will be some missing data for some patients. So following on from this particular bit of work that we do, this is not the end of the story by any means, but this is only the first approach and the first step. So the model will require independent validation in other samples. Australia, for example, might have different baseline risks of death in opioid use disorder that would need to be added into any kind of model if it was transported to any other geography. And also we need to examine its utility in clinical practice. Just because we have a model doesn't necessarily mean it might change anything for people, and doing a clinical utility study is part of the prognostic model development process, along with qualitative and quantitative evaluation of people, both people who experience opioid use disorder and professionals, acceptability of using this within practice. So we know from a large array of evidence synthesis that standardized all-cause and drug-related mortality rates are significantly elevated among people with opioid use disorder. And there's a significant body of evidence out there describing individual risk factors. However, at the moment, if you've got a patient in front of you in clinic, we often use clinical judgment alone to think about individual prognosis and the prioritization of treatment interventions within our services. It's not particularly objective at the moment. These models that we've developed provide the first accurate quantification of individualized mortality risk at baseline assessment for people with opioid use disorder. There have been models developed, largely within the United States, looking at people who are routinely prescribed opioids to look at both the diagnosis of opioid use disorder and of overdose. But we think that these are the first models to look at people attending addiction treatment services with a formal diagnosis of opioid use disorder. And as I've said, this is just the first stage. So this is not the end of the story by any stretch of the imagination. It requires independent validation. We require ongoing assessment of clinical utility and ongoing assessment of acceptability, both within professionals and clinicians. But in order to get all that done, the development and validation model needs to be published first, and people need to comment on it, and then we take it from there. So thank you very much. I'll leave you with some references and my contact details if anyone wants to contact me, particularly while I'm out here in Australia. And yeah, I'm very much looking forward to the discussion with Michael and any questions that you might have. Thank you.
Thank you so much, Emmert. That was a fantastic presentation. Just while we're wrapping up, thank you, Michael, for joining. Before I ask for some reflections from Michael, just a reminder to drop any questions that you might have in the Q&A box at the bottom of your screen, and we'll be sure to get through as many of them as we can. Welcome, Michael. Thank you for joining us. I wonder, do you have, if you wanted to offer any reflections on Emmert's presentation, given your clinical and UK specific experience?
Yeah, well, first of all, thanks very much, Emmert, for the scholarly presentation of a very, as we know, it's a very complex thing. But the first reflection is the importance of the era we're moving into, where we can use big data to look at things that previously we had using more standard longitudinal cohorts and that sort of stuff, done estimates for, and we have the opportunity now within these large data sets to get far more accurate assessment. And I think the work you've been doing, Kriana, and the linkage work here, there's lots of opportunity there for collaboration across some of that. And the other reflection I had was in other areas of healthcare now, if you go into your GP and you're actually assessed to have, we'll say, elevated blood pressure and an elevated sort of level of serum cholesterol, in some practices, what they will do is show you where your risk is for certain outcomes in relation to the general population. And the main aim of it really is to provide you with objective feedback of what the risks of your behavior. But I think the challenge here is whether that, and I think in certain ways, Emmert, that's what you're suggesting you might do, but the challenge of some of it is the knowledge of the risk is inherent to the behavior, and figuring out what would be of use to a person who injects drugs in relation to that, I think needs quite a bit of development, because simply telling somebody, you know, you're at increased risk of death, well, I know that sort of thing. So it's a question of trying to figure out exactly. I think the element that's otherwise that's very interesting is the notion of being able to use these things more quickly to provide a link between the data and either service users, people who inject drugs, or clinicians, and actually looking at ways in which that loop can be closed a bit more than it is at the moment.
Thanks, Michael. And I agree with all of those points, and I think there's a few questions in the comments that relate to that sort of implementation and communication of risk, which I might then transition to one in particular and expand on it a little bit. So Alison Beck, thank you. She asked a question: is there guidance or training around how clinicians work, how clinicians or workers can share this information with clients and collaboratively use this information to inform treatment planning? So as you were talking, Emmett, I got the sense that it's sort of multifaceted in its purpose, in you know, being a tool that the clinicians can use, an objective tool for understanding risk and using that to inform treatment planning. What does that look like? But also in communicating the risk to the person themselves and using that as a tool for facilitating sort of harm reduction strategies. I wonder if is guidance or training, is that a factor that you're looking at in sort of rolling out, evaluating this? Can you talk a little bit about your thoughts on that?
Yeah, I mean, I think that's a great question, and that's absolutely going to the heart of this. I suppose thinking about two things in particular. So one, there's a huge amount of literature out there around risk communication in a healthcare context. So, you know, and I think we all experienced this during the COVID pandemic of having a lot of different health messaging, you know, throughout the pandemic around differential risks, whether or not that be conveyed relatively, whether or not that be conveyed absolutely, what kind of risks people respond to. There's very, very little of that that's ever been done in populations of people with opioid use disorder or people injecting drugs. And I think Michael's exactly correct in that this is a different population in terms of thinking about risk perception. And it's also a different population in terms of thinking about communication, both within healthcare settings and addiction settings specifically. So I think there's a huge amount of work to be done on thinking about how we do that both accurately, compassionately, but also in a way that is evidence-based, because I don't think we have that yet. The second thing is that I agree with all of those sentiments around development and training for workers. You have to start somewhere, and we currently don't have any of these models that are implemented in clinical practice at all within really within addiction services, particularly around mortality risk. And so you sort of, in some ways, need a product to be able to think about those kind of things and discussions before you start to have the conversation. You need a specific thing to be able to ask around. Otherwise, you're sort of putting the cart before the horse in some ways. And so I hope one of the things that we can do with this is that it becomes a bit of a tool for understanding professional and patient discussions around mortality risk in general, and particularly within opioid use disorder. There's, like I said, there's a bunch of literature around how you best ways of conveying those risks, particularly in cancer. But that's a very different person sat in front of you when you're sat in an addiction clinic.
Most definitely.
Emmert, if I could say something, in the charts you showed, so you showed the young woman versus the 56-year-old male. I would like to have seen one of a male of that age who was squeaky clean.
Well, Michael, that's the joy of the web app. You can use the QR code right now and put in whatever risk factors that you want.
Okay, but it's because you know the young female to the middle-aged male there's going to be considerable difference in risk anyway.
Yes, absolutely. And baseline risk is obviously taken into account there, and that's the utility of the web tool that allows you to manipulate any of those variables that you so wish.
Great plug, Emma and Michael. I'll just request that you don't do that until we're off this webinar, playing around with that risk tool. Extending on what you're mentioning around sort of really identifying the target around what you're talking about, and obviously you've modeled all-cause mortality and drug-related mortality. We have a question here. Did drug-related mortality specifically mean mortality related to opioids or more generally related to any drug?
It's more generally related to any drug. It's a national definition that's set by the Office of National Statistics that they report statutorily on every year, and it encompasses ICD-10 codes due to any substance, due to intentional, unintentional poisoning, or substance dependence or harmful use. If you have a look in the, again, the web app will take you to a delightful link to the paper, which will show you which ICD-10 codes drug-related mortality refers to.
Thanks for clarifying that. 2 follow-up questions, quick ones. Do you know if that included alcohol, and was there a reason why it wasn't specifically related to opioid mortality?
So it does include alcohol to start with. The reason it doesn't necessarily specifically relate to opioid mortality is that the numbers are quite small. So each time you sort of go down a level in terms of the number of outcomes, you lose predictive ability. And people with opioid use disorder obviously can have significant other substance comorbidities and also are at elevated risk of death from a variety of causes, both substance and non-substance related. And one of our government's priorities is to reduce drug-related mortality, the definition of which the government uses as its own. And so part of the development process of this model was to align with our government's sort of definition of drug-related mortality.
Fabulous. Thanks for clarifying that. It's interesting to think about sort of the various considerations you'd mentioned, sort of the modeling and sort of having that preference for more traditional, less black boxy kind of modeling from the stakeholders and community involved in the project. And I imagine even the number of predictors, if you're modeling drug-related mortality, which includes all drugs, that, you know, even the question of do you use drugs other than opioid could have been another factor, but then it's at, you know, 10 plus predictors, and trying to juggle those considerations would be really a lot to handle, which is why we've got a few other questions, and it would just be interesting to understand the rationale around some of that. So yeah, maybe the inclusion of other drug use, and then also a question that we have around why smoking status might not have been included in the model.
Yeah, absolutely. I would have loved to include smoking status. It's not collected as part of our as part of any of those databases that I mentioned, which is appalling, and we have been trying to change for a number of years. And obviously tobacco smoking is a huge risk factor for both death and a variety of other morbidity factors. It's not collected, so we couldn't model it. So one of the variables that we did include was the number of substance misuse diagnoses. So whether or not they had any other, so, you know, if they all had one by definition of being in the model, because they have opioid use disorder, but some people will obviously have diagnoses of more than one. And we did model that, that was in there, but it wasn't found to be predictive in either drug-related mortality or all-cause mortality, so it didn't end up in either of the final models.
Fabulous, thank you for that. Fantastic questions, people. Please keep them coming. I'll do my best to get through them. We have one. Does the research consider if the individuals received or not congruent treatment for their condition?
So these are all variables that were collected at baseline assessment in addiction treatment. So no one is currently receiving anything. This is their first time through the door. Well, it's their time through the door, the most recent before, if they didn't die, if that makes sense. So obviously some people can have been in addiction treatment before, but at the point at which these variables are collected, they are not receiving any structured addiction treatment and not on OST.
Mm-hmm. Yeah, makes sense. And capturing also the mental health treatment that might have been received previously as a predictor in that model as well. We were talking about risk and sort of communicating that. What would we consider high risk? Do you have thresholds or any sort of take on considered high?
I think that's a great question. And no, we purposefully didn't have any kind of decision curve or threshold analyses based into these. We wanted to see if we could develop something that was accurate to start with and that was acceptable to use within services. Otherwise, again, if you develop something that has very accurate and great thresholds, but it's completely unusable, or patients hate it, or clinicians hate it, you're not going to get very far very quickly. And so, yeah, absolutely. One of the next stages is to think about those thresholds and whether or not whether or not 10% means this person gets an assertive outreach treatment, whether or not 20% means they get an extra phone call. All of those things are, interventions that are on the basis of a potential risk threshold, all of which is studyable, right? So if anyone is willing to fund any of these, if we have any funders online, I'm very happy to talk to you. But yes, I think this lends itself well to intervention studies, because you can identify a specific risk cohort of people whom you could allocate intervention X to, intervention Y to, compared to normal treatment, and whether or not they do better or not on the basis of that. So yeah, you can use this in that way, and you could use it in a sort of decision curve analysis to say a person with a score over such and such is quote unquote high risk, or you can use traffic light systems, or all of these. I mean, I think, yeah, all of these are potentially developable subsequent to this work being published. But like I said, this is the first step.
Yeah, absolutely. Lots of potential, it sounds like. Which also brings us to another question that we've got, which I think is really relevant in the context of developing prognostic models, especially using administrative data. They're very localized in their development, and geographic calibration or geographic applicability is often an important consideration, and one difficult to evaluate as much as we might like to do it. So the question is about applicability in communities different from that which it was developed on, and potentially with less accessible surfaces, so developing countries and that. Do you have any thoughts around sort of the potential for that for your model or the literature more broadly?
Yeah, I mean, I think that's completely true, and it's a problem within all prediction modeling and all prediction science. So I mean, if you go to any sort of prediction modeling webinar or discussion, they will always say, 1,000 models have been created in the last year. If you look on PubMed, 2 of them are used in clinical practice, and that's for a whole different bunch of reasons. Some of them don't have, are not externally valid. Some of them don't have clinical utility built into them. Some of them are based on, a model of 10 events and 6 patients. And in COVID, I think we started to get sort of crazy modeling happening. What I will say is that what you want if you're going to externally validate a model is for your baseline model to be very robust. And like I say, there aren't data sets of this magnitude really elsewhere in the world at the moment. I would hope that there would be in the future through techniques like data linkage. The problem is the majority of people with opioid use disorder are in Western democracies. America has an incredibly fragmented both treatment system and administrative record system. So the majority of their big data sources come from insurance databases. A lot of people with opioid use disorder don't have insurance, and so their ability to look at people in the whole, both from a treatment perspective and have their matched death records, is quite hard to get large data sets that are adequately powered to be able to do this kind of work. So I think England is relatively unique in that. It took us about 5 years to get all the permissions to do the data linkage, because there's a lot of bureaucracy that lies behind the sort of one slide of we linked these three things. It's blood, sweat and tears from a large amount of individuals. So I think, yeah, the UK, England in particular, is relatively unique in having a national database for treatment records, a national database for hospitalisation, and a national database for death records, which have the ability to be linked through statistical means. So that is a useful baseline model to start with. When thinking about sort of external validation in other geographies or over different times, best practices is that isn't conducted by the original research team, for sort of obvious reasons. You don't want to bias any future assessment of it being externally valid in other countries, in other systems. But it also requires a data set to exist and a set of researchers who have those skills to be able to externally validate data sets within that. And I think that's a huge problem. I'm not aware of infrastructure, both from a personnel perspective or a database perspective in any developing countries, that would have the numbers required and the technical expertise at the moment to do that. I would hope as time goes on that isn't the case. In terms of externally validating this data set, there is scope for doing this in Australia, which is one of the reasons I'm here. But there's also scope for doing it in other Western democracies that do have infrastructure that would lend itself to this. But you need the numbers, and you need the expertise, the willingness, funding, all of the things that come with with an academic difficulty attached to it.
Academia, hey? Yeah, absolutely. And as you alluded to at the beginning of your presentation, NDARC, in particular, Louisa Degenhardt, has championed data linkage among populations of people with opioid use disorder for several decades. And yes, the gap or the gap between the US data linkage space and other UK, Canadian, Australian research groups is noted, and I'll flag Transform, which is a NIH-funded study led by NDARC that will be looking to establish a greater data linkage research space within the US, which will be very exciting, and lend itself to validating these and doing similar sort of developments, which is really exciting. Michael, do you have anything to add to that?
No, it's just, I suppose it's the journey of where we're going to end up in terms of data management. We're in the middle, society-wise, of a technological revolution as far as data management and artificial intelligence is, and God knows if we were to try to imagine what sort of seminar we would be having in 4 years' time, it's actually hard to see how it would compare to the current shape of things.
Most definitely. I'm just reviewing the questions here and now, and I'm conscious that we've just got a couple of minutes left. So we have a question looking at older people with opioid use disorder have relatively higher risk of mortality, it looks like, from what you've presented. Is that because of comorbid diseases, or is that because of longer duration of drug use, which wouldn't necessarily be specifically related to age? I don't know if you could speak to that at all.
No, I mean, well, older people are inherently at increased risk of more all-cause mortality, even if they're non-drug using individuals. Obviously, a 90-year-old is more likely to die tomorrow than an 18-year-old. But age is an independent risk factor in this model, so it independently predicts the risk of mortality, of all-cause mortality within the next 6 months. It's not commenting on the sort of underlying reasons behind that, but yes, they're very likely to relate to the kind of things that you're talking about. So in terms of duration of drug use, but also in terms of comorbidity, all of the things that happen when we get older make us more frail and more susceptible to death than we would be if we were younger.
Absolutely. Look, there's really great enthusiasm for the tool, people mentioning that it could be a valuable addition to the core assessment document in the electronic medical record system that we have here in Australia. One of the questions sort of refers a little bit to what you were mentioning around the linkage of other data sets and sort of the look back period to be able to rely on those to inform select variables, just around sort of the recency of some of the variables and how those were defined. So recently in prison or the receipt of mental health treatment. Can you speak a little bit to how you define sort of the time frame for those, and if there was much exploration around that?
Yeah. So if we take the sort of hospital ones first, so the previous admission to an acute hospital and previous detention in a mental health hospital, they're lifetime previous admissions. And the reason for that was we toyed with having a more recent admission date. Obviously, like if you were admitted to hospital relatively recently, you're probably sicker, and thus you might be more likely to die within the next time frame. But actually, our clinician and patient involvement sort of said, what you don't want is a recovery worker there going through the records, desperately trying to see whether or not it was 6 months ago or whether or not it was 7 months ago that they were in hospital, having to go to a different system, when actually, doing some sensitivity analyses on the models doesn't increase your accuracy by that much. So we thought a blanket binary question of have you ever been admitted to hospital before was actually simpler, both for patients and recovery workers or whoever it is who's administering the tool, to be able to sort of complete in a more accurate way, but also in an easier way than going off and having to think about times and things. And that's a bad use of their time. Similarly, in terms of mental health detention, the numbers were relatively small for the number of people who were formally detained under the Mental Health Act. And so again, lifetime detention seems to make more sense as an ease of question answering, as opposed to were you in mental health hospital within the last 6 months, year, XYZ. Does that answer your question? Sorry.
Yeah, I think it does. We have another question sort of around, I guess, the point that you've just made around sort of having administrative data and having really detailed information about how people are engaging in services, but wanting to balance the utility of the model and how much that level of detail might actually add to the predictive accuracy, which refers me to another question that we've got here, which is somebody's mentioned that they were having a play with the calculator and they noticed that the risk of death increases when there's a history of addiction treatment, and they ask sort of why that might be. And I think having used data linkage before, receipt of treatment captures only those who have engaged in treatment. There are obviously people who have, say, a mental health diagnosis but haven't received in treatment. So it might indicate increased severity, but it could also indicate that they are engaged in treatment services, which might reduce their risk. So it can be complex, but I wondered if you had anything to add to that.
Yeah, no, exactly. That was, and that's exactly why we included it in the model. So yes, if you are, I suppose if you're stuck in services, if you're a person who's been regularly attending services and has represented, that might increase your risk or suggest that you're dropping out of treatment for a number of reasons, or and thus it's difficult for you to stay in treatment, thus increasing your risk. Similarly, if you've never been in treatment before, you're a particularly high-risk individual. So this is an average over the model that accounts for those things. But previously having been admitted to addiction treatment is predictive of, independently predictive of both all-cause and drug-related mortality.
Yeah, fabulous. Thank you for that, Emmert. Look, we have just hit 4 o'clock. I apologise to those who submitted questions that we didn't have an opportunity to get to, but I might just ask Michael, did you have any final comments or anything you wanted to mention before we close out?
No, I think we just look forward to having Emmert here for a while and have much further discussions and some deep reflections on what we might do together.
Absolutely. Emmert, thank you so much for your presentation today, and to you both for joining for the Q&A. I'd also like to thank everyone in the audience for joining and engaging in this discussion. Just before we come to a close, I'd like to just flag the next webinar that we have for 2025 on February 13th, Professor Bayard Roberts from the London School of Hygiene and Tropical Medicine will be talking about harmful alcohol use among forcibly displaced populations. In the meantime, thank you, Emmert, thank you, Michael, thank you, audience, and I hope you all have a fabulous rest of your afternoon.